Hi, everyone. Welcome to our ICRN webinar. My name is Amy Kim. I'm a transplant hepatologist and a translational researcher at the Johns Hopkins School of Medicine with clinical and research focus in liver cancer. I am very delighted to be here today as part of our webinar to moderate this session on primary sclerosing cholangitis and cholangiocarcinoma. We're very fortunate to have Dr. Trine Folseraas today as our speaker. So to briefly introduce Dr. Folseraas, she's a physician scientist at the Norwegian PSC Research Center and senior consultant at section of gastroenterology at Oslo University Hospital. Her PhD was in genetics and PSC, and her current work continues to focus on PSC and PSC-related biliary cancer research. She's also a committee member for the EU-funded Cost Action for European Cholangiocarcinoma Network, and a faculty in the European Network for the study of cholangiocarcinoma that we're familiar with. And Dr. Folseraas also leads the clinical research group at the Norwegian PSC Research Center and coordinates this biobank. So without further delay, Dr. Folseraas.
So thank you, Amy. It's a pleasure to be here. And thank you to the Cholangiocarcinoma Foundation and the ICRN for the invitation. I'm thrilled to have you, Amy, as a host and moderator along the way. Today's presentation is entitled The Role and Impact of Primary Sclerosing Cholangitis in Bile Duct Disease and Cholangiocarcinoma. So first, I will talk a little bit about the background on PSC and cholangiocarcinoma, a little bit about the epidemiology, clinical features, and pathogenesis. I will say a little bit about risk factors for CCA and PSC. I will mention surveillance for CCA and PSC, the implementation of novel early diagnostics testing for cholangiocarcinoma and PSC I will touch upon. I'll say a little bit about liver transplantation in PSC and cholangiocarcinoma. I will give you a short status on the genetic profiling and precision medicine in PSC-CCA, where are we now, and some conclusions and future directions, and I'm of course happy to take questions on the way. So primary sclerosing cholangitis, abbreviated PSC, what is it? It's a chronic progressive liver disease characterized by fibrotic strictures and inflammation of the bile ducts. In the majority of patients, this disease process will develop gradually into liver cirrhosis and finally end-stage liver disease. There is currently no medical cure or efficient treatment to halt the disease progression in PSC, so most patients will be dependent upon liver transplantation for long-term survival. And as I told Amy before this meeting, it's the most common cause of liver transplantation in Norway and the rest of Scandinavia. And that is the reason for our extended interest, I would say, in PSC in Norway. So PSC has many comorbidities and complications. The majority of patients have concomitant inflammatory bowel disease, 50 to 80% of the patients, depending a little bit on the geographical region. A large frequency of patients also have other autoimmune diseases, at least up to 25% of the patients. And it's very common to have other gastrointestinal cancers, most commonly cholangiocarcinoma, which will be today's topic. But these patients are also at increased risk of gallbladder carcinoma, hepatocellular carcinoma, at least in the cirrhotic patients, and also colorectal cancer for those that have concomitant inflammatory bowel disease. The primary cause or trigger in PSC is unknown, but we have some clues to the pathogenesis. We know, starting at the right side here, we know that this is a complex genetic disease where a combination of genetic and some yet unidentified environmental factors are at play. We know that the gut is probably involved in pathogenesis. There is a large frequency of inflammatory bowel disease in these patients, as I said. And gut leakage, liver homing of T cells, and also antibodies, antigens derived from the gut are probably implicated in the pathogenesis. We know that bile is toxic and that PSC patients lose the protective bicarbonate umbrella protecting the biliary epithelium. We know that there is an infiltration of immune cells in the biliary epithelium, primarily T cells, neutrophils, and macrophages. And over time, these processes leads to fibrosis and further cirrhosis and complications such as end-stage liver disease and also for some patients cholangiocarcinoma. As you are aware of, both CCA and PSC alone are fairly rare diseases. But in PSC patients, CCA is a fairly frequent complication. And PSC remains the main established risk factor for CCA in the Western countries. So the incidence of CCA in PSC is 10 to 10,000 times higher than in the general population. And the lifetime risk for cholangiocarcinoma in PSC is 10 to 20%, depending a little bit upon geographical region. So we see more PSC in the northern part of Europe, for example, than in the southern part. And there are phenotypic differences in the PSC population in northern and southern part of Europe. So we see more IBD within our PSC population in the northern part, and we see higher frequencies of cholangiocarcinoma. So there are phenotypic differences in various geographic regions when it comes to PSC. PSC patients are often young, and I would say fit at diagnosis of CCA. That is in contrast to sporadic cholangiocarcinoma, where you most frequently diagnose cholangiocarcinoma at around the age of 70, but in PSC patients, the median age of diagnosis is 40 to 50 years. So these patients are young at diagnosis of cholangiocarcinoma in general. And CCA in PSC is not clearly related to stage of PSC, at least not cirrhotic stage. And that is in contrast, for example, to hepatocellular carcinoma, which is closely linked to cirrhosis. I would say that over the last 2 decades, we have seen large improvements both in morbidity and mortality for PSC patients. We are able to treat their cholangitis. We transplant them early enough to avoid severe complications like end-stage liver disease. But still, CCA development is a feared complication which really impacts mortality and morbidity in PSC. And the real problem in PSC is that cholangiocarcinoma is so difficult to diagnose because there are overlapping symptoms and features between benign PSC and malignant PSC or PSC with cholangiocarcinoma. Cholangiocarcinoma in PSC is also very difficult to treat, both because treatment is complicated by the underlying liver disease, their PSC. And it also seems that these patients, for example, are more resistant to chemotherapy than patients with sporadic cholangiocarcinoma. So overall, this leads to a very poor prognosis for PSC patients that develop cholangiocarcinoma. And CCA is still the major and leading cause of PSC-associated mortality. So 30 up to 50% of the patient dies because of cholangiocarcinoma, if they die from a PSC-associated complication, that is. So in PSC, the most common anatomical location for cholangiocarcinoma is the perihilar, but you will also find distal, extrahepatic, and intrahepatic tumors in this patient group. CCA in PSC gives rise to a large duct phenotype, intrahepatic cholangiocarcinoma or perihilar cholangiocarcinoma. So we don't really see those cholangiocarcinomas that develops on the small bile ductules. And cholangiocarcinoma development involves activation of the peribiliary glands and the columnar mucous cholangiocytes of the large fibrils. And this large duct phenotype of cholangiocarcinoma PSC is also confirmed by molecular profiling approaches, where we have found that they lack these typical features of the small intrahepatic cholangiocarcinomas. That is IDH1 to FGFR2 rearrangements. These are really rare in PSC cholangiocarcinomas. As for carcinogenesis, it is very likely that chronic cholangitis inherent to the disease process in PSC is of relevance also for development of cholangiocarcinoma. There are several features related to chronic cholangitis that could lead to the neoplastic transformation of cholangiocytes. First of all, in chronic cholangitis, you have a loss of the protective bicarbonate umbrella. That over time leads to proliferation and also dysplasia development of the biliary epithelium. You will see an activation of nitric oxide synthase, which leads to DNA damage. We observe increased bacteria-derived lipopolysaccharides in PSC, which we know activates EGFR pathways and COX-2 pathways and may lead to neoplastic transformation of cholangiocytes. And we also see an impairment of bile acid homeostasis, activating EGFR and COX-2 again, and the KRAS pathways involved in carcinogenesis. And there is also an affection of the FXR pathways, which I will come back to. So there are multiple levels of evidence that chronic cholangitis are able to induce a neoplastic transformation of the biliary epithelium. There is also now very large interest, I would say, in microbiota profiling in PSC, of course, because of the concomitant and high frequency of inflammatory bowel disease. And what has been observed in fecal samples of PSC patients compared to healthy is that there is a loss of the diversity. This is something we see in many other diseases as well. And a striking feature is that this diversity is even more reduced in PSC patients with IBD compared to IBD patients alone. We don't yet know the relevance of this when it comes to cholangiocarcinoma in PSC, but it's worth to investigate further, I would say, whether the microbiota or microbial products are involved in carcinogenesis. So I think we will see a lot of research related to this within the next few years. The first publications are already out when it comes to PSC cholangiocarcinoma. And this is from a study investigating the microbiota composition in bile samples. And strikingly there, they find increased richness, which is in contrast to what we see in the fecal samples. And they see especially an abundance of fused bacteria. And this seems to coincide with increase of multiple inflammatory markers. So this is a very interesting finding, I would say, maybe telling us that an altered microbiome is implicated in the progression of PSC and also in the development of cholangiocarcinoma.
Trine, quick question. I'm just very interested in terms of the fact that this is independent. The fecal microbiota is independent from, what we see the common correlation with inflammatory bowel disease. So, is there a difference in? Do we have data that those PSCs who do develop cholangiocarcinoma, if they see any change compared to those who do not, independent of IBD presence, or is that not yet been done? Because I know you're comparing the cholangiocarcinoma cases.
Yes, to my knowledge, it's not yet done, but these studies, I think, are underway.
I see. Okay. All right.
Okay, thank you. So further, I would like to mention something about risk factors for CCA in PSC. We have, over the last decade, I would say, performed several genome-wide association studies in PSC, and we have identified several susceptibility factors, genetic susceptibility factors involved in PSC. And by that, we have actually defined PSC as an autoimmune disease, because what we typically find is genetic alterations that are common across many autoimmune diseases. And of course, then the question is, are there also inheritable genetic risk factors underlying this close association between PSC and cholangiocarcinoma? But throughout our GWAS studies and also candidate gene studies, we haven't really been able to identify any strong genetic risk factors. There are some weak associations to the genes listed here, but it doesn't seem that the genetic risk for cholangiocarcinoma is in PEs predominant. So we suspect that environmental factors or disease process inherent to PSC is of the major importance, not genetic risk factors per se. So we don't have any reason to genetically test these patients to identify patients at high risk for cholangiocarcinoma. As for other more clinical or biochemical risk factors for CCA development in PSC, there are some reports. We know that elevated CA-99 is a marker that is not very sensitive or specific for cholangiocarcinoma, but at least is involved. Long duration of concomitant IBD has been implicated as a risk factor, advanced age at PSC diagnosis, a MI risk score of above 4, history of colorectal neoplasia, and of course, presence of biliary dysplasia. But I would say that none of these, except from presence of biliary dysplasia, is useful to really identify a high risk group for cholangiocarcinoma and PSC. And none of these factors are really modifiable. So we can't really use them for accurate risk prediction. So in lack of any risk predictors enabling us to identify a high-risk population, we need to perform surveillance for all PSC patients. But I would say that we should intensify our surveillance when it comes to patients where we detect biliary dysplasia. I will come back to that. And I think we should be very aware of cholangiocarcinoma in patients with a recent diagnosis of PSC, because we know that up to 50% of the PSC patients get their CCA diagnosis within 1 year of PSC diagnosis. This is probably because the symptoms of CCA leads to the diagnosis of underlying PSC. I believe that we will see advances when it comes to risk prediction and risk stratifications for CCA and PSC within the next few years. There are a lot of studies ongoing in cholangiocarcinoma overall, including PSC patients. They are related to circulating metabolites in blood, serum, peptides in urine, and so on. That I think will enable us to give a more precise risk prediction. And we also have studies on biomarkers in PSC. There are several biomarkers now implicated in PSC progression, and some of these biomarkers really reflects underlying cholangiocarcinoma. An example is the enhanced liver fibrosis test that we see when it is elevated is related to reduced transplant-free survival. And this transplant-free survival is really driven in many ways by cholangiocarcinoma development. And we also see when we do sub-analysis that the enhanced liver fibrosis test is more significantly impacted in PSC cholangiocarcinoma patients compared to PSC patients without cholangiocarcinoma. So I think the biomarker studies in PSC also will be enable us to identify CCA risk predictors within the next few years. And this will, of course, enable us to identify high-risk population for which we could provide more intensified surveillance.
Before you go into the surveillance, as you mentioned, the fibrosis as a potential, I guess, when the previous slide looking into the fibrosis score or elastography, you mentioned earlier that cirrhosis obviously is not related to higher risk of cholangiocarcinoma? I mean, PSC alone is an independent risk factor. Has the kind of, population studies or clinically, do this degree of fibrosis, which I translate as kind of a continuation after inflammation, is that you think is a risk factor? And then I guess the other thing is then, episodes cholangitis, like clinically significant cholangitis in these population, has that come up to be a higher risk population to develop cholangiocarcinoma?
I don't think we have clear data showing that the frequency of cholangitis has something to say, but it's probable, I would say. When it comes to fibrosis, I think this is something that is potentially reflected by the findings from the enhanced liver fibrosis test, because we see that there is an increased frequency of cholangiocarcinoma in those with an elevated ELF test, reflecting a more severe fibrosis potentially. But to really look at it with elastography or in a biopsy derived material, that has not been done yet, as to my knowledge.
I see. No, that's very interesting.
I think it's a very interesting question whether fibrosis is clearly associated to carcinoma risk.
Excellent, thank you.
So when it comes to the current status for surveillance for CCA in PSC, I would just say that surveillance in PSC for CCA in PSC, it's not really evidence-based, but it is very meaningful because PSC is a very well-defined high-risk population for CCA. But the problem with current surveillance algorithm is that we don't really have any accurate surveillance modality, and in part we also lack efficient treatment approaches for the patient group. But still, I think centers around have been performing some kind of surveillance for many years. And this was also confirmed in a recent survey done in Europe. So more than 90% of centers in Europe actually perform surveillance in some way or the other with the tools they have. And I think they do this because patients are at high risk and we need to do something for these patients to try to detect cholangiocarcinoma early. And surveillance is now also formally being recommended in PSC clinical practice guidelines. But I still think that these surveillance algorithms that are suggested in guidelines are in need of implementation of novel and more accurate early diagnostic markers for CCA to really be efficient or sufficiently efficient. And that leads me to the next few slides, because what kind of novel diagnostic markers could we then be talking about? Among promising new markers that could be used for early detection and also for implementation in surveillance algorithms, we have over some years now been investigating methylation markers or epigenetic markers, both in tissue and biliary brushes and bile from PSC patients and PSC-CCA patients. And our most recent effort, we included a large set of bile samples from our PSC biobanks in Norway, Sweden, and Finland. And we investigated 4 methylation markers in DNA, measured that DNA derived from these bile samples. And we found by measuring these methylation markers a high accuracy for cholangiocarcinoma in PSC, also early stage cholangiocarcinoma, even premalignant stages. And these methylation test actually outperforms the results we have from conventional biliary brush cytology when it comes to detection of early stage cholangiocarcinoma. So these are promising markers, I would say, that we are now in Norway trying to implement in a prospective manner into our PSC-CCA diagnostics. Others are working on biliary brushes, doing next generation sequencing using targeted panels, and it seems to be successful both on biliary brushes. Others have been working on bile I think these kinds of diagnostic will also come into our diagnostic algorithms for PSC within the next few years. But of course, they need prospective validation and clinical implementation. And I also think that we have more and more success with using cholangioscopy with biopsy now. These are local data in the early phase where we started to use cholangioscopy and biopsies for cholangiocarcinoma detection in PSC. But our endoscopists, they are now getting more and more experience both with the visualization of the tumors. They are more and more able to distinguish benign inflammation from malignancy. And we also get more biopsy material for histological evaluation and potentially also sufficient material to do next generation sequencing from these biopsies. So these are also very promising, I would say, for future diagnostics. So the way we are working at the moment is that we try to identify early diagnostic candidates in tissue from PSC patients with cholangiocarcinoma. Then we test these markers in biliary brushes and further test them in bile. And the ultimate goal, of course, would be to try to re-identify some of these markers in blood so that we could apply a less invasive test to PSC patients for surveillance in the future. But I think we will need some years to get there. A little bit about the disease progression in PSC cholangiocarcinoma. Cholangiocarcinoma in PSC doesn't really progress overnight. It's a gradual progression and preceded by precursor lesions. And there are two main precursor lesions or premalignant lesions in PSC cholangiocarcinoma and in cholangiocarcinoma overall. The most well-known is the biliary intraepithelial neoplasm. This is what we most frequently see. But we are increasingly also being aware of the IPNBs. They seem to be more common in PSC cholangiocarcinoma than in sporadic cholangiocarcinoma. This is a premalignant lesion we know little about. It seems to be slightly less aggressive, but as said, maybe more frequent in PSC than we previously thought. We know that there is a clear association between the presence of biliary dysplasia and future cholangiocarcinoma development in PSC. There is a close association between low-grade dysplasia and cholangiocarcinoma presence or development, and even more significantly, between high-grade dysplasia and cholangiocarcinoma. But what we know less about is the grade of variability in time from progression from low-grade dysplasia to cholangiocarcinoma, for example. And we also know that some patients regress from dysplasia to a normal state, and we don't really know which factors are involved in that kind of regression. If we had known, we would be able potentially to modify dysplasia, which would be of importance. The knowledge about the close association between dysplasia and cholangiocarcinoma has led us in Norway and also the rest of the Scandinavian countries to offer patients preemptive liver transplantation in cases where we find biliary dysplasia in biliary brushes at ERCs. So the protocol, to say it very crudely, is that when we identify low-grade dysplasia or more severe dysplasia, high-grade dysplasia, in two biliary brush cytologies or intraductal biopsy, that's cholangioscopy, at two separate procedures, we offer patients liver transplantation. And when we do that, we really discuss the pro and cons with liver transplantation with the patient before we proceed. So we have patients that say, well, no, I want to wait I will not undergo a liver transplantation yet, and of course we respect that. So this is really in communication with the patients. And of course, the pros by having this kind of practice is that we, by transplanting these patients early, we really avoid that they develop incurable CCA and reduce the mortality related to CCA and PSC by doing this. And of course, we also see that these patients really have excellent outcomes after transplantation because, as said, they often have early stage PSC. They are quite healthy at the point where they are transplanted, so they do well, both at the first phase after transplantation and also long term. But the cons is, of course, that this liver transplantation is otherwise premature. These are healthy patients. If we have not detected biliary dysplasia, maybe they would have lived with their PSC liver for 10, 15 more years before liver transplantations would have been necessary. And another problem is the inaccurate diagnostics, because as said, dysplasia can regress, and sometimes our biliary brushes are probably false positive. So when we look at the explanted livers in these patients, we see that around 20% we really don't re-identify any dysplasia, and these patients have actually then been transplanted unnecessary. And of course, to have such a practice really depends upon the organ situation and the length of the waiting list, I would say, and that has been very good traditionally in Norway, and that has allowed us to have such a practice. But to continue this practice, we need to still have a short waiting list, and I think we would like to have an even more accurate test for dysplasia than biliary brushes, and we would like to have more knowledge about this dysplasia carcinoma sequence, so that we were able to even risk stratify these patients better and select and give them a better selection for transplantation. So do you have any comments, Amy? Because
I'm dying to ask questions on the slide. I mean, it makes sense. You know, in America, especially where I am, and I'm near the Washington, D.C. area. So this area, we have a long wait period. So, and for PSCs, patients with PSC, despite their elevated bilirubin, their MELD isn't as high. So they can be listed, but they can wait years and years and years and years. So I don't know if it's the same in Europe, and I imagine there is some exception pathway where if they have episodes of cholangitis. So we have a lot of speculations, right? And we always say they're high risk for cholangiocarcinoma, so it's better to transplant them earlier than later. But there's like the like you said, we know that, but we don't have like the robust evidence to prove when and how. And then secondly, logistically, it's just so hard. So just hearing this is very, I mean, I think it's great that you moved the envelope forward in terms of thinking it this way. I guess some of the challenges that I can see from, like, realistically, I find and we all do brushing cytologies from ERCP. I'm trying to remember the last time I saw dysplasia, because they always come back as atypical, atypical cells, inflammation. So I wonder, do you have like a specific, criteria that you tell your pathologist to grade? Because I understand it's very hard with these, the cells that you're showing as well. And then is it just the pathological cytopath evidence that you move forward, or do you sometimes have like adjunct markers, like there's a stricture that's do you guys do fish, or is it just all cytopath findings to move this patient forward to transplant?
Yes, it's actually mainly brush cytology finding, and we are of course very dependent upon an experienced cytopathologist to do this, and specific criteria, I would say, for the staging of dysplasia. But we have the same problem as you have, that we have biliary brush cytologies that are equivocal or lack of material. So we have to repeat and repeat our ERCs and the biliary brushings. And as said, we need to, or in most cases, we would like to see a firm diagnosis of biliary dysplasia at least twice, with the 1 or 2 months distance between the ERCs before we proceed to liver transplantation. And of course, we need to exclude that they have developed a more advanced stage cholangiocarcinoma when we proceed. So we follow these patients really closely when they are on the waiting list when it comes to progression.
Yeah. No, I guess, I mean, looking at, I guess, 20 to 25% who do not have, biliary dysplasia on histology, that, that's not too low of a number. I guess we wanted 0, but, the limitation. I mean, we'll discuss more at the end, but I think with some of the studies you've shared, including your own, with, like methylation markers and other modalities, maybe we can make it to 0 and have this successful kind of preemptive liver transplant protocol.
Yeah. Okay, so as for many other transplant centers, we have also protocols for liver transplantation in cholangiocarcinoma. These are study protocols, and these may include patients both with and without PSC, of course, but the PSC is not a reason for exclusion from these studies. So what we are aiming at is to define a subgroup of early stage cholangiocarcinoma patients where we will see a 5-year survival of more than 50%. That is sort of the threshold that we have for HCC and transplantation for HCC. And you can read some of the inclusion exclusion criteria, but to sum up, it is important within these protocols that we see that the cancer is not too aggressive, so it should be stable within an observation period of 12 months on conventional therapy before we proceed with the liver transplantation within these protocols.
Interesting.
And outside this protocol, we accept a limited number of very, very early stage cholangiocarcinoma.
Yeah, no, this is actually a hot topic here right now. Emailing multiple centers on what we should do with intrahepatic cholangiocarcinomas. So incorporating a question actually from the chat as well, and to follow up with another question, what is the kind of typical wait time for liver transplant in Norway? I guess if you can generalize it as much as possible, and then in the mean time for PSC patients.
When we started to transplant patients for biliary dysplasia, I think the waiting time in general was 4 to 6 weeks.
4 to 6 weeks, okay.
But that scenario has changed over the last few years. We also have more patients with NASH, cirrhosis, alcohol. For example, we didn't really have all these common etiologies previously in Norway, and we had very few patients with hepatitis C and hepatitis B, for example.
Yeah.
But this scenario is changing. So now I think the median waiting time is around 3 months.
3 months in general for all liver transplant waiting.
And for PSC, yeah.
I see, and including PSCs, okay. Okay.
But of course, we have patients waiting for up to a year, depending on blood group and size and so on. But,
is that right? Okay, but I guess it's on the earlier end. So I think the question is in general. So it is kind of in the shorter end. And then to more specifically in terms of your for cholangiocarcinoma transplant protocol, do you still go by like the size limitation of 3 centimeters, or do you have any different criteria for hilar and intrahepatic lesions?
As for now, we try to implement this protocol, Tesla 1 and 2, for the majority of patients. So if we accept patients outside this protocol, the maximum TNM stage is up to 2, and they should have a low CA 1919.
I see. Okay.
Mm-hmm.
And do
and
they
in many ways, it's almost an individual evaluation that we do for those few patients that we transplant outside these protocols.
And do you routinely give neoadjuvant chemotherapy, or once they get local regional, I think you wrote 10% response in chemotherapy local regional, is that one or the other, or do you try to combine it before transplant?
In the Tesla protocol, we try to combine it, but for those outside these protocols, we sometimes go directly for liver transplantation because the waiting list has been so short.
Right, right.
Mm-hmm.
Understandable. Great, thank you.
Over the last years, we have performed studies when it comes to genetic alterations in PSC cholangiocarcinoma tissue, and that has given us some insights versus precision medicine approaches in PSC cholangiocarcinoma. So a few years back, we collected a tissue collective in Europe, and also including samples from the Mayo Clinic in the US, and did a targeted molecular profiling on more than 180 patients with cholangiocarcinoma and PSC. And we detected quite a few novel genetic alterations in PSC cholangiocarcinoma by doing this. But of course, an exome or whole genome sequencing will be necessary to identify more PSC-CCA specific alterations and also additional therapeutic targets. But based on this effort, we at least now have a list of candidates, genes in PSC cholangiocarcinoma that may open for targeted therapies. So I think we know more now than we did a few years ago when it comes to the genetic molecular composition of PSC cholangiocarcinoma. But I think it's still a challenge when it comes to implementing precision medicine in cholangiocarcinoma, and this is based on the genomic characterization that is still insufficient, but I think there are exome studies on the way. And we also lack information from clinical trials in PSC because, unfortunately, PSC patients are often very few or actively excluded from clinical trials in cholangiocarcinoma. And I think we also lack clinical, real-time clinical experience because we tend to think that PSC patients will not tolerate different kinds of therapies. But I think it needs to be said that this is a patient group in great need, and they have very little to lose. So we try to implement or include these patients in precision medicine initiatives as far as we can. And we see that despite that they have sometimes advanced liver disease, they seem to tolerate many types of therapies quite well in general. You had a question for me, and that was related to Cylofexor. I mean, there are a lot of studies ongoing when it comes to both phase 2, phase 3 trials in PSC in general, when it comes to new therapies. And maybe one of the most promising findings is from a phase 2 studies on the FXR agonist Cylofexor. This was a 12-week trial using different doses of Cylofexors, where they observed a significant impact on both biochemical parameters, ALP, GT, but also on bile acid accumulation using Cylofexor. So this has now gone into a phase 3 trial. I think this Cylofexor is also very interesting in a CCA context because we know that the FXR or loss of FXR is implicated in cholangiocarcinoma carcinogenesis. But of course, we don't have any data on PSC and cholangiocarcinoma related side effects yet, but I hope we will have these data in the future. And of course, as we think that cholangiocarcinoma development is inherent to the disease process in PSC, to treat PSC adequately will potentially also reduce the frequency of cholangiocarcinoma in PSC. So novel therapies in PSC will be important, I would say, also to reduce the complication of cholangiocarcinoma in PSC.
That's great.
I'm coming to the end now, but I would like to mention PSC as a model disease. We are using PSC as a model disease for many things. We are using PSC as a model disease for inflammatory bowel disease development. We are using PSC as a model disease for recurrence of autoimmune disease after liver transplantation, because we know that 30 to 50% of the patients develop PSC in their transplanted liver. But there is also a great potential to investigate cholangiocarcinoma pathogenesis in this patient group, because we will have a subset of patients that will never develop cholangiocarcinoma that you can follow in parallel with a subset of approximately 20%, at least in Norway, that will develop cholangiocarcinoma. So it's an ideal situation to sample biobank material, both in a healthy control group and in a group that will slowly develop cholangiocarcinoma throughout the precursor lesions. So, some conclusive remarks. CCA is unfortunately a common and often fatal complication in PSC, and early recognition remains a challenge. And I still think that improved early detection tools are urgently needed. And surveillance, as of yet, for CCA in PSC should be offered to all patients at all stages of PSC. And I think we should make efforts to further molecularly characterize CCA and PSC, and also to include PSC cholangiocarcinoma patients in ongoing precision medicine initiatives. So thank you for the attention. That was all from me.
Thank you so much. That was fantastic. You know, even as a hepatologist, I was trying to absorb all the information. And you know, I'm actually, you know, learning a lot in terms of that transition from PSC to cholangiocarcinoma, because oftentimes we're a little too late, right? We see it after the fact and try our best to manage. So there were a few questions to me and some questions that I had. Just going back to the, you know, in the HCC world, I think the liquid biopsy really kind of shot up in terms of the interest and actual implementation. You know, none of them are FDA approved, but you know, we're starting to use that and across many other solid tumor cancers. The ERA curve you showed is great. I mean, you know, in terms, I think specificity always has been the issue with some of the tumor markers. And you did mention, you know, the goal is to be less invasive, et cetera, like with blood and other modalities to detect. Has there been even like a pilot to see if this could be, you know, something that's feasible in, you know, plasma or any other fluid, like gastric fluid? I don't know if there has been. I wasn't sure, so that was my one question.
Yes, we have we do now biobank duodenal aspirate to see whether we could use this methylation test on duodenal aspirates obtained with gastroscopy, which would be less invasive, but we are not sure yet. It's a considerable dilatation or dilution. I'm sorry. So we will see whether that works. When it comes to blood, we have done some pilots when it comes to methylation, and it seems that we need very large volume of blood to be able to extract sufficient DNA for this methodology. But here we are trying to improve our protocols. So this is work in progress.
Yeah, no, that's great. And you mentioned about, as in the spectrum of dysplasia, the biliary epithelial like neoplasm, and the intraductal papillary neoplasm, as in the process of the development of cholangiocarcinoma. I guess, when pancreas disease, we oftentimes have a surveillance protocol for, IPMNs. We have, I guess, in cirrhosis as well, we have these screening methods. Why is it that, oftentimes in clinical guidelines, and for reasonable, I understand that with complications, we discourage ERCPs or endoscopic evaluations. But, I mean, do you think there could be a utility in screening endoscopically and kind of following these dysplasia that we see on tissue?
By doing ERCs.
Right. So if we see, say that among the PSCs, we see the intraductal like papillary neoplasm or evidence of a high risk, then should that person undergo a separate, more of an aggressive screening measure for earlier detection? Or
yes,
did I miss the point?
There is a potential there. I think it's difficult to really follow all PSC patients with ERCs because it's an invasive procedure, of course, and has its complications. But for patients where you have identified a risk factors like dysplasia or IPMB, we tend to do follow-ups with ERCs.
You do.
And new evaluation, new brushings, new bile sampling, etc.
Like an annual screening, all right.
No, more frequent actually. At least when we find, I said, say biliary dysplasia, we do it after a maximum of 2 to 3 months. But of course, that is because we then will offer patients liver transplantation, so
right,
it has a direct consequence.
Yeah.
So it's difficult to say what other centers should do.
Yeah, no, I understand the difference there. Yeah, no, that's very interesting. I think I need to circle back to our pathologist and have further discussions on how we can better characterize our findings. I guess we don't have that much time in the last few minutes. In terms of, as an expert in PSC, both in the lab and, in the clinics, what do you think is number one, one, is there a pipeline in the medical management that you think you're really, really looking forward to? You mentioned FXR agonists, there's, research in PPAR. Is there something that you think is really going to be changed if we have validation studies? And then number two would be, what is your ideal management algorithm that you would recommend to all, physicians if you had unlimited resources?
First, I would like to say that I think almost all this phase 2 and 3 studies ongoing in PSC, all the clinical trials ongoing in PSC is very interesting, and I hope and I think that we will see results that will change things for patients, because we have been doing a lot of research on PSC, but it remains to have clinical impacts. And I think medication that can modify disease progression and hopefully also the frequency of cholangiocarcinoma as a complication will be essential. And your next question, the ideal follow-up of PSC patients in general, I will say it's very important to follow them. And what we do is that we follow them at our hospital annually with ultrasound, elastography, MRCP, a blood sampling with CA1919, and then we leave it to the local hospital or their general practitioner to follow them an additional 2 or 3 times a year with the clinical follow-up and blood samples. I'm not sure if that is the ideal follow-up, but that is at least what we are able to offer these patients. And then we have a close communication with the GPs following these patients that they should contact us in case of elevations in their cholestatic parameters, or if they have cholestatic symptoms, weight loss, etc., etc., etc. So I think it's also a question of making those that follow PSC patients locally aware of the disease and the common complications, so that we see these patients at an early stage when they have complications.
No, I think that's important, and that's great to kind of see your algorithm. I think oftentimes we do see, as a specialist, we see them definitely annually unless something new, arise clinically. But you're right that a lot can happen with even fluctuations in labs within that year. I mean, we try to do more close lab checks, but as you know, you mentioned, a lot of our PSC patients are young, healthy, working, busy young parents. So going to the lab every 3 months or 6 months is a challenge, which I understand. But elastography, definitely, that is not something that we do commonly. And that's something I think we should look into, especially given the recent studies on the fibrosis measurements as a risk factor. And one question, would you agree that one of the challenges in PSC kind of research advances would be the small number? And I imagine, multi-center trials and multi-center research is very valuable. What do you think? What do you think is the limitation, I guess? In terms of having more of that, like, is it funding? I mean, just for the purpose of our cholangiocarcinoma foundation, like, is it the funding mechanism? Is it the education? Or definitely we have initiatives, but what would you like to see so that we can kind of advance that area?
I think to build networks is very important, and this is what we saw within the International PSC Study Group that was established in 10 years back, that we, by building a network in Europe and the USA, was able to collect a large set of blood samples for these genetic association studies in PSC. They were really large multi-center studies. And I think this is also what we now see with the ENSCA initiative, that we are establishing a network across disciplines, which I think is also very important. So I think we will, and we already see that it is easier to establish multi-center studies also in small diseases like PSC and PSC-cholangiocarcinoma. And this I'm for sure will give results. And the next thing is, of course, that you will need funding, not only nationally, but to perform such studies. And this is still a challenge, I would say.
Yeah. I know there's some mechanisms here in the United States with NIH with rare diseases, and we forget that PSC actually qualifies for that. So it's one funding mechanism that could help, but I think we need more. But with that, I think we finished all the questions and we're right on time. So thank you so much, Dr. Folseraas, for your talk and your expert input. Unless anyone else has any last minute questions, we'll end the session. Okay, thank you.
Yeah, thank you as well.